Let's jump right into pediatric CNS clinical pattern decision logic. For step 2, we are focusing strictly on age, timing, mechanism, and exam-facing management.
We're looking at these high-yield newborn and childhood presentations. Things like open spinal defects, a lumbosacral skin marker, a head that's rapidly enlarging or abnormally shaped, scalp swelling right after delivery, neonatal focal weakness, a premature infant showing neurologic decline, or an infant with abnormal tone or developmental delay. We'll map these exact patterns straight to the mechanism and what to do next. Here we're comparing the anatomy. You see the normal spine, then closed spinal dysraphism, all the way to open defects, like a myelomeningocele where the spinal cord is literally exposed. When that neural tube completely fails to close, you get this open spinal dysraphism. So what's the risk factor here? That failure of the neural tube to close is heavily tied to maternal folate deficiency or the use of antifolate drugs. And for the patient, a myelomeningocele brings lifelong comorbidities. We're talking motor and sensory dysfunction, neurogenic bladder and bowel, hydrocephalus, and significant orthopedic deformities like scoliosis. When you see this at birth, your immediate priority is to prevent infection and heat loss. You do that by covering the sac with a moist, sterile dressing and applying plastic wrap. That's step 1, followed by urgent surgical repair. Down the line, long-term care means clean intermittent catheterization, a structured bowel program, bracing, and eventually surgical correction of those deformities.
Moving to closed spinal dysraphism, pay close attention to the skin. A cutaneous marker is often your only initial clue on the exam. A lumbosacral hair tuft, a subcutaneous mass like a lipoma, or an atypical dimple, especially if it's large or high above the anus, these all point to a failure of the posterior vertebral arch to fuse. If that occult defect leads to a tethered cord, the distal spinal cord dysfunction is essentially stretch-induced. On the boards, watch for a patient presenting with back pain that gets distinctly worse when bending. You'll also see lower extremity weakness, hyporeflexia, gait abnormalities, and foot deformities like pes cavus or a hammer toe. Urologic signs are huge here too. Think urinary incontinence or retention leading to recurrent UTIs. Get an MRI of the spine to evaluate it, and if there's symptomatic tethering, they need surgical detethering. Now let's talk about hydrocephalus. The whole presentation hinges on whether those cranial sutures are open or closed. If the sutures are open, they allow for a rapidly increasing head circumference, macrocephaly, prominent scalp veins, and a full fontanelle. But once those sutures close, the head can't expand, so the symptoms shift to mimic increased intracranial pressure, headache, vomiting, papilledema, impaired upward gaze, hypertension, and bradycardia. In a severe newborn case like this, you can clearly see the prominent scalp veins and the bulging fontanelle. Your imaging choice absolutely depends on that fontanelle. If it's open, evaluate immediately with an ultrasound. If it's closed, or if the patient is older, you want an ultra-fast MRI if they're stable, or a CT scan if you're worried about acute signs of increased ICP. Let's map out the head sizing logic. For microcephaly, you first identify a head circumference below the 3rd percentile. If it's benign, the patient will maintain a stable growth curve with normal development, a normal neurologic exam, and no dysmorphic features. But concerning microcephaly, which you'll spot by declining major percentiles, neurologic symptoms, or dysmorphic features, needs a workup. Order an MRI to evaluate for structural, genetic, infectious, toxic, or vascular causes. We prefer MRI over CT here simply to spare the kid from radiation. On the flip side, what about a large head? We consider it benign macrocephaly only if there's completely normal development, no syndromic features, and 0 signs of increased intracranial pressure. Usually you'll also find a positive family history of large heads, and these cases just require regular monitoring. Differentiating abnormal head shapes is a classic board scenario. Cranial synostosis is the premature fusion of those cranial sutures, which causes abnormal skull growth and a real risk of increased ICP. Positional plagiocephaly, however, is just mechanical molding from their sleep position. The sutures are totally normal and there's no ICP risk. Now, for neonatal scalp swelling after delivery, the anatomical boundaries dictate your diagnosis. A cephalohematoma is a subperiosteal bleed, meaning the blood is trapped right between the skull and the periosteum. Because of that, it absolutely does not cross suture lines. Compare that to a caput succedaneum, which is just subcutaneous edema above the periosteum, so it easily crosses the sagittal suture. Timing and texture also give it away. Cephalohematomas usually show up hours after birth as firm, non-fluctuant masses. Most resolve with simple observation, but keep in mind that the breakdown of all that trapped blood increases the newborn's risk for jaundice.
Then you have subgaleal hemorrhages. These cross sutures like a caput, but they are soft, fluctuant, and expand over days. This is a big deal because it carries a serious risk of life-threatening blood loss. Shifting to the brain parenchyma, let's talk about neonatal stroke. These are often tied to congenital cardiac disease, prethrombotic disorders, or sickle cell disease. They can present quietly at first, but watch for acute seizures, encephalopathy, or subsequent focal weakness that eventually results in hemiplegia later in infancy. This timeline is super helpful for tracking pediatric seizure and vascular risks by age. In premature and low birth weight infants, your highest risk is intraventricular hemorrhage. As they move into infancy, the focus shifts towards syndromes like infantile spasms. Then in childhood, you're looking out for conditions like Lennox-Gastaut syndrome, which presents with multiple seizure types and severe developmental impairment. Speaking of infantile spasms, here's the classic vignette. An infant presents with developmental regression in clustered, brief flexor or extensor spasms. You get an EEG, and it shows hypsarrhythmia. Immediate first-line treatment is crucial here. You go with ACTH or prednisolone. The one exception, if the patient has underlying tuberous sclerosis, vigabatrin is your specific drug of choice. Finally, we have cerebral palsy. Remember, this is strictly a non-progressive motor dysfunction caused by early brain injury. Prematurity and low birth weight are your major risk factors. Spastic diplegia often shows up early as commando crawling because the lower extremities are so affected. Meanwhile, spastic hemiplegia typically presents as an abnormally early hand preference in an infant.
And because that initial early brain injury affects multiple pathways, every single cerebral palsy patient needs rigorous screening well beyond just their motor function. You absolutely must screen for vision impairments, hearing loss, feeding difficulties, seizure disorders, hip displacement, and other developmental comorbidities. Managing these is the key to optimizing their long-term outcomes.